Welcome nonetheless. Again, I want to thank you for the opportunity. Wendy Chapman, who asked me, was my mentor and left me to join you. So I'm a little angry and jealous a little bit about the whole experience, but she's a huge asset to the community. So I'm honored to speak at her invitation. I'm also fascinated because I'm speaking from the U.S. to Australia. We had our paediatric surgery grand rounds last week, given by a Polish surgeon from Poland who couldn't make it to the U.S. And so one of the benefits of the pandemic has been, I think, making very easy bridges across large oceans for intellectual curiosity. So I'm honored to speak here today. I tend to talk fast, and I can't gauge the audience when I'm speaking because I can't see you very well. So please, if you have questions or want clarification, please just interrupt me and just ask. It's just much easier that way. I have a hard time monitoring the chat through Zoom for it. So let me share my screen here. And let me switch screens here. Sorry for a second. Okay. Much better. Okay, can everyone see my screen?
Yeah, perfect. Thank you.
Great, awesome. So today I thought I would talk to you about my journey and experience in leveraging artificial intelligence to in the field of surgical health services research. And who am I? I view my career or my path as a Venn diagram, and I'm first and foremost a practicing pediatric surgeon. I have the privilege to operate on small babies and not so small adolescents, and I really get to see kind of in real time the needs of the patient and how digital health can really impact patient care. I'm also have interest in health services research. I'm fascinated on how we can make healthcare cheaper, safer, and more cost-effective. And I'm interested in developing tools to help drive health in that direction. And I'm also a biomedical informaticist, and I'm fascinated by the application of math and informatics to medical diseases and how mathematical modeling can help drive digital healthcare solutions. And so I'm kind of view myself in the middle of this intersection of clinical care, research, and health services work. And I'll give you a little taste of what I've done in my short career time to drive these areas forward. In full disclosure, although I'm a pediatric surgeon, nothing I'm going to say today has anything to do with children. And so when I talk about patients, I'm really talking about adults. And I can get into that for a number of reasons, but all the research that I do is on adults, and all the work I do developing tools is on adults. And so no children were harmed in the making of this presentation. So I'll just start with a question that's driven me for a couple of years now is, what if we had a learning healthcare record? And this started to me a long time ago when I was a resident doing my training of surgery. I had to do a project on infectious complications after surgery. And so I had to review charts. And so every day after my clinical responsibilities were done with, I would go down to the bowels of the hospital in the basement in medical records and pull the charts of about 250 people that had an infection after surgery. And I would read every word for hours on end just to obtain data to do this project. And I kind of think to myself, there has to be a better way to do this. I mean, there simply has to be a better way than me spending hours down here. And that's what kind of has started driving my career is leveraging the EHR to improve patient care. This, just to kind of put medicine in perspective, because I'm sure all of you have cell phones, all of you use Google. And so this is just a simple graph that kind of demonstrates where do certain AI or artificial intelligence applications sit on this spectrum? And you can imagine an AI application can have a very narrow focus, doing one simple task, or a very general focus here on the right. Or its underlying architecture can be very, very simple or very, very complex. And so where do some common AI solutions fit in the space? Well, for those of you that remember, Deep Blue was the first AI program that beat Garry Kasparov in chess. Siri was later developed in the mid-2000s by Apple. Self-driving cars are becoming more commonplace, particularly in the US. And now IBM Watson won Jeopardy a couple of years ago, and is probably the most general AI solution out there. But where are we in medicine? We're unfortunately down here in the left bottom corner with very, very simple and very, very narrow use cases. So clinical decision support, for example, allergy notification, drug interaction notification, are very simple AI tools that are commonly used in medicine. Some of the more advanced applications include computer-aided detection of mammographies to identify breast cancer. So compared to the general AI sphere, medicine is in the prehistoric ages, unfortunately, with that regard. And so just think about how much information we put into the electronic healthcare record. We put in notes, we put in labs, we put in radiology, we put in pathology reports, and what do we get out? We get out the same information that we put in, same format, untransformed, same structure, etc. And so my career has been spent thinking about, okay, how can we make this better? How can we get more information out than we put in to help improve patient care? And so the way I think, again, as a surgeon, I think very simply about my field of expertise, which is surgery, and what are some opportunities for learning EHR to improve surgical care? And as a surgeon, we joke, everybody in the world is either preoperative or postoperative. So everybody should care about surgical diseases, because at some point or another, you will have had a surgical procedure. And so in the preoperative arena, a learning EHR can help with risk prediction, can help with shared decision making about understanding the consequences of surgery, can help the clinicians with perioperative optimization to reduce complication risk. Interoperative, it can offer decision support for both anesthesia or surgeons. Really cool applications for computer vision, because surgeons are very visual. And so, can we create some computer vision tools to help make surgery safer? And on the postoperative side, can we, again, develop tools to help decision support, risk prediction, surveillance for complications, or improve perioperative patient engagement? And so there's a whole spectrum of applications where AI or a learning EHR can help improve patient care. Today, I'll talk about two specific applications. One is the detection and surveillance of postoperative complications, and the second is the use of conversational agents or chatbots in the surgical arena. And so why should you care about surgical complications? Well, as a surgeon, I would love to tell everybody that I'm perfect, that I can get you through an operation safely, that you're going to recover without problems, you're going to go home to your family. Unfortunately, that's not the reality. Is that surgical complications are a major problem in the surgical arena. And the reason being is because you get this domino effect where a patient may have a simple complication, let's say an infection in the urinary tract. And that may lead to some delirium, that may lead to a fall, that may lead to a readmission to the hospital, that may lead to other infections like a pneumonia or an ICU admission, and ultimately it may result in the patient's demise. And so surgical complications are the initial domino that can really drive morbidity and mortality in the postoperative space. And so if you look at complications, they're very common. About 16% of invasive surgeries will have some form of complications. One complication increases your risk of mortality by 5-fold. For the penny pinchers in the room, it's very costly. About $7.5 billion US healthcare dollars are spent on surgical complications. And here's the thing: is that 42% of them, if identified early, can be either prevented or mitigated. And so there's a lot of room to improve the quality of surgical care if we can better identify surgical complications. And so because of their importance, there's a number of registries in the United States that focus on surgical quality. And these registries are run through various organizations. And what they usually involve is a human, a nurse, or a quality officer who manually reviews the charts of patients undergoing surgical procedures and identifies those that have complications or not. And then that data is fed back into the QI process to help identify measures or areas for improvement. However, there are several problems with that approach. The first is case sampling. Because you have a human reviewing things, it's physically impossible to review every chart. It's just not, it's too costly. So we have most programs rely on a sampling strategy to allow for broad surveillance by randomly sampling cases. Because of that, you have variability between institutions. Some institutions look hard, some don't. And so some institutions have better outcomes than others. And is that because of a bias in surveillance? It's very expensive. The programs themselves run somewhere between $200 to $300 US dollars per hospital, mostly spent on humans to spend time reviewing the charts. And therefore, these efforts are not scalable across hospital systems. For example, small community level hospitals can't have the resources to do quality assurance, surgical quality assurance, because they just can't afford it. It's too expensive given their volume. And so what outcomes are we talking about here? Well, some of the outcomes that we care about are easy to identify. For example, if you died or someone died, that's a relatively easy complication to find because those events are tracked quite readily in the healthcare system. If you had to go back to the OR for another operation, that's easily tracked. If you came back to the hospital, that's easily tracked. But some of the ones that are the kind of nidus for these big events like death and reoperation are very challenging. For example, a surgical site infection, an infection in a surgical wound, it can be very challenging to find in the jargon that is the EHR. Urinary tract infections, pneumonias, blood clots, like for example, pulmonary embolisms or DVTs, myocardial infarctions or infection, C. diff infections can all be very challenging to find, like a proverbial needle in the haystack. And the reason they're challenging to find is because they all rely on text. So, for example, this is the Centers for Disease Control in the U.S. definition of an SSI. And you can see here that the definition requires words. It requires a human to interpret words. And that makes it very difficult for a machine to understand whether a complication happened or not without understanding human language. And so this is the reason why most surveillance systems for surgical complications rely on the manual chart review process. And so my group has spent quite a while to develop models and tools to help identify surgical complications from text. And I'll just give you a kind of a brief overview of how we do it. The first thing is we acquire data, and we need data, particularly labeled data, to help develop models. We then obtain text or free text from the medical record to analyze, and then we develop models, and then we do our analysis. And so I'll take you through a couple of use cases. So I work in a number of healthcare institutions. I'm going to show two here. One is the University of Utah, which is my academic institution. And the second is Intermountain Healthcare, which is a not-for-profit healthcare system in the state of Utah. They're two completely separate entities, two completely separate EHRs, two completely separate patient populations. And so we've strived to develop tools that can be used across healthcare systems to make it generalizable. So we've taken data from about 5,000 patients, 9,000 at the University of Utah and 16,000 Intermountain over the past decade. And we obtain labels or outcomes from one of these quality registries. So these are data that a human has reviewed and demonstrated that the patient did or did not have a complication. And we use these labels to develop our models to help detect the complications that the human tried to do in the first place. So you can see here, the complications we're going to talk about are a surgical site infection, a urinary tract infection, a blood clot, such as a deep vein thrombosis, or a pulmonary embolism. And as I mentioned, it literally is the proverbial needle in a haystack, in that these events that we care about, thankfully, don't happen to a lot of people. So SSI, which is the most common, happens in about 5% of the population. But for example, PE or DVT, which can be life-threatening, fortunately only happen in 3 out of 1,000 patients. And so they're very rare events. And this is ideally suited for predictive modeling or AI, because for rare events, you can't have a human that looks at all these charts all the time. It's just not feasible to abstract all this data given the rarity. You'll have to review thousands of charts to even find a handful of cases. And so what we're trying to do is identify if an event happened after a surgical procedure. So we obtained EHR data from patients from the time of surgery to about 30 days after surgery. And we use 30 days that is the kind of nationally accepted standard for when the event should occur for it. So I may say the words prediction or model, but what I really mean is case detection. I'm not trying to predict if the event's going to happen. I'm trying to predict, did the event happen? And so we utilized natural language processing, which is an area of computer science which seeks to understand human language, and particularly medical language, which is different than human language, because medical language has a number of problems with it that makes it uniquely challenging for NLP. The first is clinicians are lazy. We don't use punctuation. So we don't write complete sentences. We write fragments quite frequently. We use a lot of jargon like AP and POD and SP, and so we use a lot of terminology that's not really common in general language. And so a lot of NLP tools that have been trained from Google, for example, on Wikipedia or news articles don't really apply to medicine, because again, clinicians are lazy and we don't use appropriate grammar or spelling to do this. And so what we've done is what our goal is to take a note that looks like this, a very simple SOAP note for those that are clinicians in the room. And we want to break it up into sentences and words and convert this note into some structured format that a computer could read. So for example, in this note, I want to know if there's a surgical site infection present. So the AI system or the NLP system should be able to tell me if there's a surgical site infection, when did it occur, where did it occur, how certain are you that it occurred? Is it a probable, maybe, definitely not? Was there negation? There's definitely not an SSI compared to there definitely is an SSI. The temporality, did it happen recently or is this historical? For example, did the patient have a history of an SSI rather than an acute SSI? What evidence does the NLP system use to ascertain its final conclusion? And then where did the infection occur? And so what our NLP system does is it takes all the patient notes for after the surgical procedure and breaks it down into individual notes and breaks it down in individual sentences. And then from each sentence, converts it to a structured format. And then using a combination of rules and probability, aggregates all of the mentions to come up with a patient level conclusion. Did this patient have an SSI? Yes or no? And so the advantage of computers is that we can take thousands of notes and run this on a laptop computer, and it will run this in real time with very little memory needed, and computing power needed. So for those of you that are interested in model development, what we did was we took our data sets and we broke it down into a training data set where we trained the NLP system and iteratively revised our rules and our probability matching to maximize the performance. And then we tested our NLP system on a blind test set at one institution, something called internal validation. So we use the same data. We use data from the same institution as training, and then we used data from external institution, external validation, to demonstrate generalizability of our approach. And so what the data here I'm showing is the sensitivity, or how likely is it if you had the complication that our NLP system did find the complication. And you can see here, for example, during internal validation, our surgical site detection sensitivity was 94%. For urinary tract infection, it was 75%. For pulmonary embolism, it was 71%. And for DVT, it was 85%. So again, looking for the proverbial needle in the haystack, this is pretty impressive performance. Instead of having to review thousands of notes, an NLP system can easily flag notes that are likely to have complications. We then demonstrated that the system can be used in a separate healthcare environment. So we tested it on external validation to a different EHR. And as you would expect, different hospitals, different languages, different physicians, different terminologies, different acronyms and spellings, et cetera, et cetera. So you do have some performance drop here. Interestingly, some of the thromboembolic events, our performance actually went up, which is fascinating to me, why it went up in external validation. But I think this demonstrates proof of principle that you can develop tools in one healthcare system and demonstrate that they work in a separate healthcare system. The challenge, currently, what we're doing now is taking our NLP solution and integrating it within the electronic healthcare record to automate this process. And so what our current work is on is taking our surveillance tool and integrating it within the EHR, within our EDW, to have an automated tool where quality assessment officers or quality assurance officers can log in and get automated reports on what is our complication rate in real time from the EHR. And then we're also trying to take our NLP data and understand, okay, if we can just because you called it positive, what's the evidence for that positive label? How can we explain our reasoning to humans? And so this is a mock-up of a dashboard that we're creating for a nurse or a quality officer to say, if this patient had a complication, what's the evidence? And these are the sentences and these are the documents that the NLP system used to make the ascertainment that the patient did have, for example, a pulmonary embolism. And this, the goal here is to make the chart review process, or the quality assurance process of surgery, much more efficient, scalable, and more importantly, explainable. So just to conclude our NLP, I think just as a flavoring, NLP can be used to accurately identify postoperative complications from the EHR. It's got a high sensitivity, and we believe it can be used to augment the manual chart review process and really make surgical quality assessment much more scalable and cost-effective for healthcare systems. I'm going to pause right there because I've talked a lot. Are there any immediate questions on the NLP AI part of this talk?
Can I just ask you to comment, Brian, on the sort of it takes a village aspect of this project?
And it kind of leverages our NLP expertise, and that is the use of conversational agents in healthcare. And so conversational agents or chatbots are AI programs that engage with users by text. They interpret questions or concerns, and they respond automatically through text messaging, either or imaging or in a voice format, etc. So this kind of leverages the NLP expertise that we've developed in helping to understand how can chatbots or conversational agents be used in the healthcare space. And so just a little bit of terminology. Conversational agents are very similar to the use case I just showed you. So for example, if you opened up a COVID chatbot on your phone, you could text the chatbot, can you give me information on COVID-19 vaccine sites? And behind the scenes, the chatbot does the exact same task I just talked about, which is information extraction. It converts that sentence into a structured format for a computer to read. So for example, the intent or the goal of the question was to request information regarding COVID-19. They want the immunization, they want to talk about immunization, and they want to know locations. And then the chatbot has a message generator that will interpret this structured input and say, okay, here are sites for COVID-19 vaccination in Salt Lake City. And on the behind the scenes, you have a conversational agent that has intent classification and response generation that is linked to the electronic healthcare record. And so you can imagine for that use case we literally just talked about of the patient not coming back to the hospital, one way of ensuring those patients don't get lost to follow-up is to have a chatbot or a conversational agent that will interact with the patient and will perform surveillance and increase engagement, etc. So this is taking the expertise we've developed, trying to detect complications, and using it for patient-facing tools. And hopefully this will work. Sorry, I'm going to keep sharing my screen here for a second. Sorry. But let me just stop my. Can you still see my screen?
Yeah, we can still see it.
Okay, so this is a chatbot that our group has developed that could be used to engage patients after surgery. So you can imagine that you're at home recovering from surgery, you have a cell phone, and you get a ping from my office that says, "Hi, I'm a chatbot. I'm interested to see how you're recovering from surgery. Is now a good time to talk?" And you can respond with text, and the chatbot can do a number of things. It can, for example, answer common questions after surgery. So you left the hospital, you had all this paperwork, and you want to know, I don't know when I can bathe. So you can ask a question like, when can I bathe? And the chatbot will understand what you want and can provide you consumer health information about your recovery process. The other thing it can do is it can provide surveillance. It can ask you, how are you feeling? And if you have any complications. So for example, it can ask you, how are you feeling after procedure? And let's say you're not doing well, and you say, I have a fever. It would understand that, and it would start asking you more questions, and then could notify the surgeons or the physician's office that, hey, Mrs. Smith is not doing well. She needs to be seen in clinic. And this system can run in the background without needing significant human input. So let me stop there and restart my slides. So we're just at the forefront of this, and that chatbot I just showed you has probably been developed in the past couple of months. You know, there's a lot of areas about conversational agents in healthcare that are unknown. Will patients trust them? Should we be transparent in that the fact that they're just talking to a human? Are they safe to use? What about privacy and confidentiality? How do you integrate them within clinical workflows? Is there inherent bias in the chatbots, language or interactions? What are the legal ramifications of giving medical advice through a conversational agent? So this area I think is ripe for exploration, and we're pretty excited to delve into the space, because it really takes the use case I just talked about, which is surveillance from medical records, and understanding how clinicians talk about how clinicians document health, to understand how do patients talk about their own healthcare, how do patients describe symptoms. That's an area that's ripe for exploration. So this is, in my opinion, the kind of more interesting aspect of my work is trying to create patient-facing tools that can be used to improve safety and quality. So you can imagine this kind of chatbot or these health IT tools are a bridge between the clinician and the patient and the EHR. And I could talk a whole hour on the kind of barriers and challenges to this type of approach to healthcare. But I'll just kind of touch on just a few things to think about as you all are kind of navigating this space with the challenges for AI in health. A couple of big challenges that I've encountered and thought about, and as I've navigated the space. The first is ethical, regarding data ownership and bias, and the second is technical, about interoperability and explainability, which we talked about briefly. So who owns your healthcare data? And I'll be honest, I don't know in Australia, but I can tell you in the United States, it varies by state. It's pretty ambiguous. So this is a map of the US. The majority of healthcare data is owned by the hospital that generated the healthcare data. Only in the state of New Hampshire does the patient themselves own their own healthcare data. Every other, however, in the majority of states, it's unknown who actually owns that data, who has rights to that data, who can use that data. It's unclear, and this is an area that is becoming increasingly difficult to work through as vendors, HR vendors, have become quite dominant in the medical space. The second thing I worry about is bias, and this is a fascinating example from Google. For those of you that speak Turkish, I don't, but for those of you who speak Turkish, the Turkish person pronoun, he or she, is the same word, o, and it's gender neutral. And so in Google Translate, if you typed in they, or this ambiguously gendered pronoun, is a doctor, it would translate that into English, he is a doctor. If you translated this gender neutral pronoun is a nurse, it would choose she's a nurse. So there's inherently a gender bias in the data that we use to train Google Translate. And this bias exists in all of our documentation, in all of our language. Unfortunately, if we rely on the inherent biases that generate the data, all of our models would be biased themselves. Second is interoperability. As I mentioned, we don't have a national healthcare service in the United States, and unfortunately, even EHR vendors during implementation make decisions that are local in nature, and so therefore we joke that if you've seen one version of Epic, you've seen one version of Epic, and one version of Epic doesn't necessarily talk to another version of Epic, and so interoperability, or getting data to talk to one another, getting EHR systems to talk to one another, is hugely challenging. And lastly, as I mentioned, is explainability. Clinicians are going to need to have explainable AI. Just giving a label is not going to do it. And so if you're going to call this a duck, you got to tell me why do you call it a duck? It's got feathers, it's got wings, it's got bills, it's got webbed feet, et cetera, et cetera, et cetera. Same thing in healthcare. If you're going to say the patient is at high risk for PE, you need to tell me why that's the case. And if it's not explainable, it will not be used. So I'll kind of end with, again, a thought here. What if we had a learning healthcare record, electronic healthcare record? What are the potentials that we can accomplish? And I mentioned things that I'm interested in, but the reality of it is that AI has permeated our lives, and our patients are going to be first order participants in their healthcare. They're going to want to know and use the most cutting edge technology to drive their own healthcare. So patient-centered outcomes, precision medicine, computer devices, information-powered patients of the future. And if we're not leading in this space, we're gonna be reacting in this space because patients are going to demand it. So I will stop there and stop sharing my screen. And again, I'm very thankful for the opportunity to talk. And again, I'm happy to